It's my pleasure now to introduce our first speaker, who is Dr. Kara Wyant. She's a clinical lecturer in the Department of Neurology at the University of Michigan. She received her medical degree from the University of Toledo College of Medicine. Dr. Wyant completed her neurology residency training at the University of Pittsburgh Medical Center, where she served as chief resident from 2015 to 2016. She is currently pursuing and about to finish a fellowship in movement disorders at the University of Michigan, focusing on the medical and surgical management of patients with Parkinson's disease and Parkinsonism. Dr. Wyant also served on the neurohospitalist service at the University Hospital and participates in teleneurology consults for Mid-Michigan Health. Teleneurology, as you understand, is a really growing area of providing care. So Dr. Wyant is here and will be speaking on an overview of Parkinson's and treatment options, and we very much thank her for coming.
Hi, good morning. Thank you so much for having me this morning. I'm very excited to be here with you to talk to you about Parkinson's disease and then to spend the majority of our time talking about the management of the motor symptoms of Parkinson's disease. So first, just so we're all aware, I don't have any relevant financial disclosures to let you know about. We're going to start, like I said, about kind of getting everybody on the same page. So what is Parkinson's disease? What's the typical course of Parkinson's disease? How do we make that diagnosis? And when do we use ancillary tests in order to support that diagnosis? And then spending the majority of our time talking about the medications we use to treat patients with Parkinson's disease, about when we start treatment and how we decide that, how we decide which medication is best, and once motor complications start to arise, how do we treat those? So first, Parkinson's disease, as we all know, is a progressive neurodegenerative disease. We don't know what causes it in the vast majority of cases, but what we see on autopsy slides is that there's an accumulation of alpha-synuclein inside the cells of the different parts of the brain. The one that causes the typical symptoms we see in Parkinson's disease are the accumulation of those proteins in the dopamine-producing cells of the substantia nigra, which is this picture down here on your right. And the accumulation of that protein forms into these kind of round pink inclusions, which we call Lewy bodies. Now, Lewy bodies don't just form in the dopamine-producing cells of the substantia nigra. They can also affect multiple other different parts of the brain. So Parkinson's disease right now affects approximately up to 1 million people in the US and 10 million people worldwide. It typically affects older people, with only about 4% of the cases diagnosed before the age of 50. And males are about 1.5 times more likely than females to get the disease. So like I said, we're not exactly sure what causes it. Only about 10% of cases are genetic, meaning that it runs in families, runs in your DNA. The majority are thought to be due to complex interactions between environments, so things we're exposed to during life, and genes in our DNA which predispose us to that disease. So going a little bit into the course of Parkinson's disease. So many years before the onset of the motor symptoms of Parkinson's disease, patients can already start to develop symptoms. And those include and are typically non-motor symptoms, like REM enactment behavior. So that's the punching, kicking, screaming, acting out dreams at night, or loss of smell or decrease in smell, or constipation, or anxiety, or depression. And then the motor symptoms, when they start, typically start on one side, and then slowly over the course of 3 years progress to involve the opposite side. And typically the course is very slow. Initially, patients are usually diagnosed within their first 3 years. It can take longer if there's not the tremor, because that's kind of the red flag where people start to go to the doctor to look for things. And they typically do fairly well until they reach the middle stage of the disease, which is probably around 5 years after the diagnosis, where they start to develop what we call motor complications of the disease. So these are the fluctuations, where they go from on, where their medications work really well and they're able to do what they want to do, to off, where their medications aren't as effective and they fluctuate on and off throughout the day. Or they develop other long-term side effects of dopamine therapy, like dyskinesias. And those are those extra involuntary movements. When I'm talking about those to my patients, I say, you know, have you ever seen Michael J. Fox where he's just kind of all over the place when he's doing his interviews? Those are the dyskinesias. So then as the disease progresses, by about year 15 of the disease, the non-motor symptoms, which we're going to hear more about in the next lecture, tend to predominate and become the main features of the disease. And as the disease progresses, by the end, the majority of patients will have cognitive impairment meeting criteria for dementia. So how do we make this diagnosis of Parkinson's disease? So Parkinson's disease is a clinical diagnosis. So we make this by talking with our patients, asking them, when did your symptoms start? How did they start? How are they progressing? And then also doing a physical exam and looking for specific signs on the physical exam. And those specific signs we're looking for are called Parkinsonism, so the motor symptoms of Parkinson's disease. So Parkinsonism is defined as bradykinesia in combination with rigidity or resting tremor. So bradykinesia is the slowness and smallness of movement, but it's the decrement in speed and amplitude that happens with repetitive movements. So when we're testing this in clinic, we'll ask our patients to do rapid alternating movements, finger tapping, fist opening and closing, pronation, supination, stomping, toe tapping, things like this. And then watch as they do those movements to see, does it get smaller and slower over time as they're doing them? So patients don't typically come into my office and say, you know, I've been slowing down. Some do, but the majority of the time they have a hard time describing their symptoms, and it's more of a weakness or an incoordination in the affected limb or a tiredness. So the bradykinesia that we see doesn't just cause a slowness on exam. It will also cause some of the classic signs that we see in Parkinson's disease, like the classic Parkinsonian gait, where patients will start to shorten their stride length, be more slow, and shuffle their feet. Or the micrographia, which is the smallness and teeny tiny handwriting. Or hypophonia, the soft voice. Or a masked face, where they just kind of stare at you. So I have a couple videos of some patients here. And what you can notice is that this patient, we're asking her to do really fast, big, fast finger tapping, and they're slow, and they get smaller as you go. And then here we're reminding her, please do them really big and as fast as you can. And they get big for a second, and then immediately get slow again. So the next one here, you can see this gentleman's face, this kind of masked face, where he just kind of stares at the camera, his mouth is a little bit parted, he's not moving it at all. That's the typical masked face of a patient with Parkinson's disease. You can also see in his alternating movements that they're very small and that very tiny. He has a hard time even turning his hand all the way around to get started on that left side. This gentleman here has much more subtle signs. Look at his left arm. You can notice when he's walking, his gait looks okay, but that left arm doesn't swing as much as the right arm. So this is much more mild bradykinesia. So the second sign, motor sign that we see on exam is rigidity. And this is the increased tone that appears when the doctor passively moves, so that's without your help, moves the range of motion around a joint. And this should be increased throughout, no matter which direction the doctor is moving the joint in. And sometimes you'll have a tremor. So it'll kind of catch, 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 catch. And that's what we call cogwheeling rigidity. This leads to this rigidity, this increased tone, leads to the classic stooped posture of patients with Parkinson's disease. So kind of flexed at the waist, this kind of forward flexion of the head, the bent knees, the bent arms. And patients with this will have problems with difficulty getting out of chairs and rolling over a bed. In addition to the problems, this can also be caused by bradykinesia. So this next video is a gentleman who's attempting to get out of the chair without using his arms. You can see he has pretty bad difficulty, so he has to push himself up. And when you see him stand, you can see the typical posture, where his arms are a little bent, He's forward flexed. You can see his knees are a little bit bent here as well. This gentleman has, again, a little bit more subtle rigidity. So look at his left arm. When we're just kind of slowly swinging him back and forth, his left arm doesn't swing as much as his right arm. And that's because there's increased tone at the shoulder joint on one joint compared to the other. So the classic finding that I think most people identify with the Parkinson's disease, in addition to the gait and other features that we've mentioned, is the tremor. Now this tremor is different than other tremors in that it's a rest tremor. So it's there when you're not paying attention to it. And when you go to do things, it should disappear in the majority of cases. It's a low frequency, so a relatively slow tremor as to how we think of tremors. It's typically thought of as the classic pill rolling tremor, so in the hand where it goes back and forth. But it can also be seen in the tongue, the lips, the jaw, the chin, and even in the legs. And while it usually goes away with activity, it can come back. So in a doctor's office, physician might have the patient lift up their hands, and it might go away for a second, but then slowly start to come back. And that's the reemergence of the tremor. The clue for this tremor versus other kind of tremor disorders like essential tremor, which can also cause a tremor in the hands, is that this tremor typically doesn't affect a patient's ability to do things. They can still write, they can still feed themselves, cut their food with a knife and fork, and do other things. It's not disabling usually. So this lady in this video has a tremor, a resting tremor in her right hand. And what you can know is it's relatively slow. It's just there in her hand. She's kind of telling her story, and that's why it's coming out. And then she'll realize here just in a second that she has the tremor. She'll kind of suppress it by making a fist, getting it to go away for a second. And then as she just relaxes and starts to talk again, it starts to come back. This next video also shows that the tremor can kind of come out when you're distracted. And one of the ways that we'll distract patients is to have them walk. So if you can see, and I know that it's fairly small, the tremor is here in her, still in her right hand, comes out as she's walking. So in addition to the motor symptoms of Parkinson's disease, there are many non-motor symptoms of Parkinson's disease that can affect anywhere from memory to behaviors, including hallucinations, can cause a lot of autonomic problems by affecting peripheral nerves and other parts of the brain. And I'm not going to talk about this any more than just to say that they're there, and you'll learn a lot more about them in the next lecture. So again, just to reiterate, when we make the diagnosis of Parkinson's disease, it is a clinical diagnosis. So that's based upon talking about the history and how symptoms got there and looking at those exam findings, looking for that Parkinsonism. And then looking for specific clues that suggest that, yes, this is Parkinson's disease versus something that looks like Parkinson's disease. And so those clues are a dramatic beneficial response to dopaminergic therapy, to the carbidopa, levodopa, or dopamine agonists. And this should be a patient feeling almost like they're normal. So not just, yeah, I think maybe it helped. It should be a dramatic response, and it has to stay. And then there's the presence of levodopa-induced dyskinesia, so those extra involuntary movements like Michael J. Fox has. Now, these typically don't present until a little bit later in the course of the disease, so they're not very helpful initially when making the diagnosis. And then the third, just specific clue that really points towards Parkinson's disease is that resting tremor. It's not present in about 30% of patients, but in the majority it's there, and that is a hallmark of this diagnosis because there's not many things that do it. The only other thing you really have to be aware of is that drug-induced Parkinsonism, so something that looks like Parkinson's disease that's caused by drugs, can have the resting tremor. So as you can see on this next slide, there are many, many things that mimic Parkinson's disease. And so what we do when we're taking the history and when we're doing the exam is look for red flags that would suggest that it's one of these other mimics and not Parkinson's disease. So some of these red flags, looking for an abnormal course. So a course that's really fast because Parkinson's disease is slow. Progresses over years, so it shouldn't progress over weeks to months necessarily. looking for the fact that it's on both sides and not just one side and then moves to the other side, looking for the fact that there's no non-motor symptom involvement, that there's no progression, that patients have just remained the same for 5 to 7 years that they've been following with their doctor. It's a little bit of a red flag. And then no response at all to the levodopa. And then looking on their medication list, this is very important to remember that there are a lot of drugs that can cause something that looks identical to Parkinson's disease. So it's important to review the medication list and look for these. So these would be your antipsychotics and even specific antiemetics. Reglan and Compazine can do this because they're just versions of antipsychotics. And then there's multiple other medications which have also been shown to do this. So it's important to ask your doctor, are any of my medications causing my symptoms? And then looking for other things that cause atypical Parkinsonian syndrome. So again, not classic idiopathic Parkinson's disease. And some of those signs that we might see on exam are cerebellar findings or really bad autonomic function where they have a lot of orthostatic hypotension, they fall and pass out all of the time, suggesting that this is something like a multiple system atrophy, or prominent problems falling, losing their balance early in the course of the disease, prominent memory problems that are different than what we see in Parkinson's disease, suggesting this is a tauopathy, something totally different than a Lewy body disease like Parkinson's disease. We're looking for symptoms that are only in the lower part, so only in the legs. So the only problem is that they have problems walking for many years. And this is for longer than 3 years. They never develop symptoms in their upper extremities, their face, or anything else. This suggests that it's something else going on in the frontal lobes, something like a vascular Parkinson's disease, so due to multiple strokes or vascular disease over time. So when do we use supportive tests? So I've said now 2 or 3 times, Parkinson's disease is a clinical diagnosis. And right now, there are no tests that are going to specifically say, yes, this is your diagnosis. So you have to rely on your physicians to know how to take a good history and how to do a good exam in order to make that diagnosis. Sometimes my patients will come in and they'll have had a DAT scan, and this is becoming more common. Unfortunately, DAT scans are not diagnostic of Parkinson's disease. It supports that there is loss of those dopamine-producing cells, but it doesn't point to and say, yes, if that's abnormal, you have Parkinson's disease. Because unfortunately, a lot of those mimics that were on that slide that I showed a few minutes ago also can have abnormal DAT scans, okay? So when is this helpful? This test is helpful when patients have predominantly the question of, is this essential tremor or is this early Parkinson's disease, which is tremor predominant? And then this test is very helpful in helping to differentiate because you can treat those 2 very different ways. Other ways, if somebody has something that looks like drug-induced Parkinson's disease and you think that maybe they have underlying Parkinson's disease as well because it's continuing to progress, this test might be helpful in differentiating underlying Parkinson's disease versus just drug-induced Parkinson's disease. A PET scan is also a useful way to help confirm the diagnosis of Parkinson's disease versus one of these other mimics. However, this is not readily available and it's fairly expensive, so it's not something that's typically done. So again, Parkinson's disease, seeing a neurologist or movement disorder specialist in order to confirm the diagnosis is right now the best way to make that diagnosis. So now we're going to move on to the motor treatment, so the motor symptom treatments of Parkinson's disease. And we're going to do this by just kind of going through a few cases and kind of talking about how we would approach management for them. So the first one is Mr. P. He's a 65-year-old right-handed gentleman, has a history of high blood pressure, presents with the evaluation of a tremor in his left hand. It's not bothersome to him. His wife was the one that actually pointed it out to him about 9 months ago. He says that he does punch, kick, scream, act out his dreams at night when he sleeps, and that he has had a little bit more difficulty getting out of chairs than he has had in the past, but in general, he can do everything that he wants to do. On his exam, he does have some mild asymmetric bradykinesia, rigidity, and a little bit of left hand resting tremor. So we think that the most likely diagnosis in him is probably idiopathic Parkinson's disease, given the history and the exam. So, do you recommend starting a medication? If so, which one? So this kind of gets to the basis of when do we start medications and why do we start medications? So currently there are no approved therapies that are available that show that they have reversed or slowed the progression of Parkinson's disease. And that's very important. It means that all of our medical therapies right now are just to treat the symptoms of Parkinson's disease. So to reduce the symptom burden, so if people are bothered by their symptoms, we start treatment, or in order to help them maintain independence. So they're slowing down to the point that it limits their ability to walk, to move around, and to do things. That's a reason to start treatment. But medications are not needed unless motor symptoms are bothersome. So you don't necessarily have to start treatment right away. So first-line therapies, in addition to exercise, I'll throw that in there, are typically carbidopa-levodopa or Sinemet, and there's an immediate release and a controlled release formula of that. Dopamine agonists, like pramipexole, ropinirole, and rotigotine, or MAO-B inhibitors, like rasagiline or selegiline. So which one is best? So many options. So studies comparing pramipexole, ropinirole, and carpergolide, which are those dopamine agonists, with levodopa, showed that if you started with the dopamine agonist versus starting with the levodopa, that it could delay the onset of motor complications. So those are those motor fluctuations, the on to the off, and the dyskinesias that we talked about earlier. So sounds good. Why don't we do that with everybody? Because there are a few things that the literature has also showed us. As you follow those cohorts out further, 6 and 10 years respectively, what you see is that over time, the motor symptom complications are not that different, that patients initially actually had better motor response with the levodopa. Even though they had an earlier onset of all these dyskinesias and motor fluctuations, they could move around better and do more initially when they were treated with that. And also, dopamine agonists initially had a lot of extra side effects. So they increased sleepiness, lower extremity swelling, and then also these other things called impulse control disorders came out. And what we know is that up to 15% of patients who are on these dopamine agonists can have impulse control disorders. And that's defined as the inability to control the impulse to do things, even when they know it's going to harm them or someone else. And that's something like pathologic gambling, hypersexuality, inability to control their spending. It can be very bad. So with this, and this long-term data that shows, there's really no long-term benefit to starting one versus another with all these side effects, a lot of people will favor starting with Sinemet, okay? And so just a couple things to know about Sinemet. Sinemet, again, is to treat the motor symptoms of Parkinson's disease, and you are most bothered by motor symptoms when you're awake, so you want to dose it during the day. So while it's dosed 3 times a day, it's not morning, noon, and night. It's before breakfast, lunch, and dinner. So you get the benefit while you're awake and moving around. And this should be given about 30 minutes before meals in order to kind of separate it from protein, which can interfere with the ability to break it down. And then side effects that you should know about and be aware of are the common ones are kind of nausea, fatigue, and this thing called orthostatic hypotension, which is the lightheadedness and dizziness as you stand up. And those are the most common when you first start this medication. As the disease progresses, you can get the motor complications, so the motor fluctuations and dyskinesias years into the treatment, but also some patients can start to develop some cognitive fogginess, so they'll just say, I just can't think quite straight, or hallucinations can develop later in the course. As I mentioned, there's a controlled release formula of this, which means that it's kind of a delayed onset release. So while the benefits are maximally beneficial for the immediate release within an hour, for the controlled release, it takes a little over 2. We use this and kind of substitute these when patients are having problems with those kind of peak dose effects of the Sinemet. So you take it and then they have really bad nausea. You can switch one to the other. That's a reasonable thing to do. Or overnight, like when they start to develop symptoms later in the night. So the controlled release, switching to the controlled release at night might be reasonable. One way to start this in early treatment. So just a few problem solving for our physicians who are in the audience today. So you give the patient carbidopa-levodopa, has some intolerable nausea and vomiting. What can you do? What are some ways so that you don't have to completely stop the medication, you can give it a good trial? So first, try moving it and taking it with food, taking it with breakfast, lunch, and dinner. Typically, separating it is more important as the disease progresses. So you can try, just try take it with food, see if you can tolerate it a little bit better, at least so we can get a decent trial. Another way is to add an extra dose of the carbidopa, which prohibits the levodopa from being broken down in the stomach, which causes the nausea and vomiting. And so you would dose this extra carbidopa 30 minutes before the dose of the Sinemet to see if that's helpful. And then, as we discussed, kind of changing from the immediate release to the controlled release to see if they can still have the beneficial effects of the Sinemet without having those kind of peak dose side effects. But what if your patient comes back in and says, it's not working? I don't feel any different. I don't think that this medication is working whatsoever. So it's important to remember, what are we trying to treat, okay? The medications that we have for Parkinson's disease that I am discussing treat the motor symptoms of Parkinson's disease. The stiffness, slowness, so the bradykinesia, the rigidity, and the resting tremor. And of those, resting tremor doesn't always respond to these treatments, okay? So if you are just trying to punch down the tremor with this Sinemet, it might not work right away, okay? But look for other improvements in the slowness and the stiffness. Make sure that they're taking their doses appropriately. It's not uncommon that I'll tell my patients, tell them about the 30 minutes before the meals, and they come back and they're like, oh, I'm taking it in the morning, a little bit in the afternoon, maybe before I go to bed. So make sure, are they taking it before breakfast, lunch, and dinner? Try increasing the dose. Sometimes the starter dose of 1 tab 3 times a day is not as beneficial. And then consider referral to a movement disorder specialist, because as you go up and you're increasing the dose, you're still not seeing a response. Maybe this is one of those Parkinson's disease mimics and not actually Parkinson's disease. So moving on to dopamine agonist therapy, so pramipexole, ropinirole, and rotigotine. So these have been shown to be beneficial for the treatment of motor symptoms in early Parkinson's disease with and without the carbidopa. It can be considered as first-line therapy in young onset. So remember those studies we talked about how it delays the onset to motor complications? Patients with younger onset Parkinson's disease will have more dyskinesias. So it's reasonable to start this medication early on patients who are diagnosed before age 50. It's kind of a gray area as to what medication you start the dopamine agonist versus the levodopa in between age 50 and 60. And after age 60, it's generally thought that levodopa is the best medication to start. But if you're a young onset, it's a reasonable option. But just as a reminder, the impulse control disorders that can come as a side effect of these medications actually are more common in young onset patients. So you really have to monitor these young onset patients closely if this is the medication you're going to start. Other common side effects, very similar to the ones that we see with the levodopa, but also sleepiness and sleep attacks are a big one to watch for, especially in the younger population who's still driving and working. And then dopamine agonist withdrawal syndrome. So this is almost like a psychiatric syndrome where patients will become severely anxious and have almost panic attack-like symptoms as you try to taper this medication. And the only way really to stop these symptoms is to put them back on this medication. And this is challenging as a clinician because this is more common in patients that have the impulse control disorder, so you definitely want them off this medication, but it makes it very hard to get them off of this medication. Another kind of thing that holds us back from prescribing this routinely as a first-line therapy. So why not an MAO-B inhibitor? So that was also on those first slides of which medication to start. So what studies have shown is that there is mild symptomatic benefit with rasagiline and selegiline for patients with early Parkinson's disease. There's also a couple studies, Tempo and Adagio, that did show that it was possibly neuroprotective at the rasagiline 1 milligram dose a day. So the problem with this is that those studies, that they have a lot of confounding factors. So right now the recommendation is not that this is neuroprotective and use it for everybody. It's that we're still looking into it. But in patients that have those extremely mild symptoms, like the patient from the initial case, and they're not bothered by their motor symptoms, they don't have significant comorbidities, meaning anxiety and depression, because you can't use this medication or need to use it very cautiously with people that are on depression medications, this would be a reasonable option to start. Something to think about. So moving on now to more of the motor complications of Parkinson's disease. So Miss M is a 72-year-old woman, has a 7-year history of Parkinson's disease. At her follow-up appointment, she complains that her tremor will worsen about 1 hour after each dose of her medication. 1 hour before each dose of her medication. She's tried moving the doses closer together. This doesn't seem to make the tremor any better, and also makes it much worse at night, so she can't fall asleep. She's currently taking carbidopa-levodopa, 2 tabs at 7, 12, and 5, so about every 5 hours. She's upset because her medications don't work as well as they have in the past, and currently, or more recently, people have already started to notice that, your head kind of bobs and you kind of sway when you're talking, when you're taking your medication. So this kind of gets to the point that over time, patients don't respond as well to their medications and start to have side effects of these medications. So this graph here kind of shows that initially, when patients are taking their medications, they have a large therapeutic window, and that's this kind of teal color here, meaning they can take their dose and it can last the whole time, and there's no problems making it to the next dose, everything works fine. But as the disease progresses, this therapeutic window gets what we call more narrow, gets much smaller. So they're still taking the medications, but now they don't last all the way between doses, and then they have this kind of overshoot of that therapeutic window, which can cause side effects. And the levodopa dyskinesias is one of those. You can also get levodopa dyskinesias as people are wearing off as well. So in this case, the best way to start to think about how do I manage somebody who's now, their medication is not working quite as well. It's not lasting to that next dose. So a couple options. So first you could change the frequency. So it's lasting about 4 hours instead of 5. Why not push those doses a little bit closer together? Or try increasing the dose of the Sinemet so that they don't have to take it every 4 hours. They can still take it every 5. Just give them a little bit more dopamine. Consider changing to the controlled release because it's a little bit more of a delayed release, and so it'll last a little bit longer than the immediate release. The problem is once patients start to wear off, then they have to wait, sometimes up to 2 hours before their symptoms get under better control. So it's a little bit hard to kind of move this around, use this one. And then you have adding dopamine agonists or adding extending medications, which can lengthen the life of the levodopa. So, and then at this point, we would recommend that you consider a referral to a movement disorder specialist. If they haven't already seen one in order to confirm the diagnosis, this is a good step to kind of say, okay, what's the next best option? Because as we're going to review in the next 6 or so slides, there are many different options and many different ways that you can start to adjust medications in order to get these patients under better control. So when you're talking about treatment of motor fluctuations, the first thing to do is to consider how can I adjust the dopaminergic therapy, and then think about what can I add to it and to extend its life. And then once these medication options fail, talking about surgical options, which they'll discuss more later this morning. So dopamine agonists also have the indication to be used with levodopa in order to kind of extend the life. And so these can be an important key and important part of managing motor fluctuations. One that I didn't mention earlier is apomorphine or Apokin. And this is a subcutaneous injection. And this is for patients who have fluctuations such that they're without warning. They'll just turn off. And so you don't want to wait the 1 hour to 2 hours for your medication to kick in. So you can give them an injection, get them turned back on, and have them take then the dose of their next medication. So there are a few limitations, though, with this medication, in that it can cause severe nausea. You're giving them a dose right away, sub-Q, so it's like taking your pills. If you're having any nausea with just your pills, you're probably going to have more with this medication. So you have to actually treat them with a medication in order to prevent nausea for 2 weeks before you can even try this medication. And then when you first try this medication, you have to be monitored by a physician because it can lead to significant low blood pressure when you're standing, cause people to pass out and fall. So other things you can do is look to change the immediate release or the controlled release Sinemet to an extended release Sinemet or Rytari. And this, so in patients where you're having to take it multiple times a day, every 3 to 4 hours, this is a reasonable way in order to kind of spread out the number of times patients have to take this medication. And it decreases off time by a little over an hour in patients that are having frequent on and offs. Side effects similar to that we see with any of the regular levodopas. The problem with this medication, though, is it's still relatively new, so it's still relatively expensive and hard to get. And then we move on to talking about instead of just changing the dopamine input, how can we extend the life of the dopamine that's there? And these are the dopamine extenders. So if you look at the picture on your right side of the screen, this is the dopamine breakdown pathway. So levodopa is what we give you. Dopamine is what it's broken down to in order to work in your system. And then from there, that's further broken down by COMT and MAOB. And those may sound familiar because those are the things that we inhibit, meaning we block, in order to increase the amount of dopamine that's available, thereby extending the life of the symptom control from the dopamine. So COMT inhibitors, entacapone combined with levodopa, which is Stalevo, have shown to decrease off time by, again, a little over an hour each day. Side effects, though, is that because it extends the levodopa, it also makes all of those side effects worse, okay? But it also can allow you then to decrease off of the Sinemet a little bit. And the other one that you should be aware of, in case your doctor doesn't tell you, is that it can turn your urine orange, okay? It's not toxic, there's no problem with it, but it definitely can do that. And then the MAOB inhibitors, again, blocking that breakdown step so that there's more dopamine available. And this is the rasagiline and selegiline. So according to Largo and Presto, which were two big studies that looked at rasagiline, it has been shown to decrease off time and almost up to an hour on most days when it's used in addition to levodopa. So not quite as good as the entacapone, but pretty good. Side effects with this, very similar to what we already talked about. You just have to really watch and make sure that it's not going to interact with any of the antidepressant medications. Safinamide is a newer drug. It was approved last spring. The big mechanism of action and how it works in Parkinson's disease is similar. It is the MAOB inhibitor. There are some other sodium channel blockade and glutamate modulation, which I think maybe they were hoping would have a little bit more response. Right now, we don't have a significant response or can say what that really does in order to make this better. But what the studies have shown is that it improves on time without bothersome dyskinesias by about 60 minutes. It decreases the off time, very similar to the other MAOBs. So it is a good medication, but it's, again, brand new, so relatively expensive. And then zonisamide is the last one that I'm going to tell you about that can extend the life of the Sinemet and has been shown in a randomized controlled study to do so. The problem with this is that this was an anti-seizure medication that was then studied in this population. And so the biggest side effect with this is sedation. It makes people sleepy. So moving on. So Mr. D is a 78-year-old gentleman. He has a 10-year history of Parkinson's disease, complains of severe and bothersome dyskinesias. They're present about 50% of the day. They're present almost the entire time that he's on and disappear about an hour before his next dose of medications. He's currently taking Sinemet, 2 tabs every 4 hours with entacapone, and the extended release ropinirole, 6 milligrams daily. So you discussed that, you're probably a good candidate for surgery at this point, and he says, I don't want surgery. What other medications can you give me? So this is getting more complex. How many of you at this point would see a movement disorder specialist or refer there? So just as a reminder, dyskinesias are the long-term side effect of medication treatment. And risk factors for this are younger onset PD, increased disease severity, and higher doses of levodopa. So management options for this, since this is a side effect of dopaminergic therapy, is to decrease levodopa, either by dose. If you do it by dose, though, it probably won't last as long as it has, so you might have to move the doses closer together. Stop the extending agents, which the entacapone is one of those extending agents, but again, be aware, you may have to move the doses of levodopa closer together to help with the motor function. Changing to a dopamine agonist. In the certain group where patients aren't having any cognitive impairment, any problems with hallucinations or anything else, or ICDs, this is reasonable to increase the dopamine agonist that they're on and kind of try and taper off some of the Sinemet. This is a reasonable option to help with the bothersome dyskinesias. And then consider changing to a longer acting formulation so you don't have these high peaks and valleys, that it's a little bit more smooth throughout the day. And then finally, adding a medication to dampen those dyskinesias. And amantadine is the first one that we think of. So amantadine, or there's an amantadine ER now available, has been shown to decrease the severity of dyskinesias by about 40 to 50%. The caveat being is that if they have underlying cognitive impairment or hallucinations, this is not a good drug for them because this can worsen those two symptoms. It can also cause a lower extremity rash called livedo reticularis as well. Clozapine is another medication that has a study that shows that it improves the amount of on time without bothersome dyskinesias by more than 2 hours a day. However, clozapine is an atypical antipsychotic that has a really bad side effect where it can affect the blood counts. And so you have to do frequent monitoring, which I think really limits this medication use in our patients. So finally, Miss F. So she's an 82-year-old woman with a 12-year history of Parkinson's disease. She complains of more difficulty walking over the last year. Her feet will stick to the floor when attempting to start walking, going through doorways, or turning around. This causes her to fall about 2 times a week. She doesn't think that it improves when she takes her carbidopa-levodopa. So a couple other motor symptoms that we can see in patients with Parkinson's disease are freezing of gait, and that's where patients will complain of their feet getting stuck to the floor. You can see it in this gentleman. His right foot gets stuck such that he can't turn around. Typically happens when initiating gait, when changing a floor pattern, so going from hardwood to carpet, or going through doorways. So any kind of change in the environment can trigger this. And then postural instability. And this is that loss of the ability to catch oneself when you lose your balance and you fall. So in the office, we check that by pulling patients backward to make them lose their balance and see, can they recover? Can they catch themselves, or do we have to catch them? These motor symptoms typically do not start until later in Parkinson's disease. If they're present earlier, it should be a red flag that this is one of the atypical Parkinsonian syndromes and not idiopathic Parkinson's disease. Unfortunately, our medications and all of those many medications that are reviewed with you today don't have much of an effect on this. There are a subgroup of patients who their freezing of gait will respond to Sinemet. So you have to really ask them, do you feel that this does get better when you are taking your medications? Because then it may be responsive and it may be beneficial to increase that dose of their Sinemet. But at the majority of the time, as the disease progresses, this happens no matter if their medications are on or working or off and not working. So with that, the best option is physical therapy. So treadmill walking, aerobic exercise, strengthening, and balance for those that still have the mobility in order to do these things. We've tried a lot of other kind of nifty different things, virtual reality, the Wii board, and all of this other stuff. Unfortunately, a lot of these studies just haven't shown as much benefit as we would like. So standard physical therapy is the best way right now for these. And they can often, when there's a lot of freezing, give you a lot of cueing and other things that we can do in order to teach patients with these gait disorders in order to be able to walk more normally and how to overcome the freezing. So in summary, Parkinson's disease is a slowly progressive neurodegenerative disease that causes both motor and non-motor symptoms, which you'll hear about next. The cardinal motor features of Parkinson's disease are that bradykinesia, rigidity, and resting tremor. All but the tremor respond very well to the medications that we talked about today. The carbidopa-levodopa is the best initial choice for patients with Parkinson's disease, but dopamine agonists and MAOB inhibitors can also be used in the right situation as initial therapy. And then it is important to remember that you should consider the movement disorder specialist as an ally to help you with confirming the diagnosis and with starting to treat these patients once the medication management becomes more complicated. Because as you saw, there's a lot of different options, a lot of different ways to treat these symptoms. So referral to a movement disorder specialist is recommended once patients start to require treatment with 2 agents for their Parkinson's disease or start to develop these other motor complications, the motor fluctuations and dyskinesias. Thank you so much for your attention today.